Hello, my name is Crystal Riccio. I am Associate Professor here at Roseman University, and I'd like to be able to provide you with some pre-class information, and this is regarding menopause for PHAR 522, and we will pick up after this video in class and cover the remainder, including the therapeutics for menopause. So to begin with, we're going to go through learning objectives for menopause are listed for you. These are all related to evaluating, identifying the transitions through menopause, what's going on, what's causing it, and then finishing up with the treatment and creating a care plan for someone who is going through menopausal transition. So to begin with, menopause is important because all women as they age will eventually experience menopausal transition. All females that are between the ages of approximately 45 and 60 will go through menopausal transition, and being that most women live to be into their 80s, that means that approximately 1/3 of their life is spent post-menopausal. So this is definitely going to be something that affects all women as they age. And there are some things that cause this to happen sooner in their lifespan, and then some things that cause it to be delayed. However, there are also some factors that are known to be myths that do not actually contribute. And so to begin with, some of the factors that do affect the age of menopause is cigarette smoking, tobacco use in general will cause a female to go through menopause sooner, approximately 2 years sooner. And then a woman who has experienced a hysterectomy will enter menopause earlier than someone who has an intact uterus. So remember, hysterectomy is removal of the uterus with preservation of the ovaries. So even the uterine tissue, as it's removed, will cause earlier onset of menopause in her lifespan. However, the ovaries are really what will determine immediate onset of menopause. And then another factor is shorter menstrual cycles. So as you'll learn, the menstrual cycle is approximately 28 days. Some people will experience shorter menstrual cycles, some longer menstrual cycles. So shorter menstrual cycles will cause earlier onset of menopause. Maternal age of menopause can help to predict the age at which a female will go through menopause. This is not always going to be known to the female, so if she doesn't know at what age her maternal parent went through menopause, or if there's anything that could have affected that age, you may not know what age the natural menopausal transition will occur, but it can be a good guide. And then parity, so having children pauses the time of onset to menopause. So if someone has frequent pregnancies that happen in her lifespan, she will delay her onset to menopause. And that's where we have some patients or some individuals who have experienced 18 children and still having children into their 50s and 60s is because they've delayed their onset to menopause by having so many children in their lifespan. So in comparison, someone who's had numerous children or numerous pregnancies will pause their onset of menopause. And then here are some of the myths that some people have historically believed, and so you can assuage these myths. The age at which you start your menarche or start having periods does not affect the age of menopause. Ethnicity, contraceptive use, alcohol, and other socioeconomic conditions do not affect the age at which a female will experience menopause. So just reviewing things that do affect it: cigarette smoking or tobacco use, hysterectomy, shorter menstrual cycles, maternal age, and parity. Menopause refers to the loss of ovarian function and subsequent hormone changes. Most of these changes are related to a significant drop in hormonal function. And so this is a normal process. It's natural to enter through menopause. However, there are times where we would do a bilateral oophorectomy. So bilateral oophorectomy is removal of both ovaries. Removal of ovaries means cessation of estrogen production, and so then that would cause immediate onset of menopause. Some medications can affect the way that our hormones function as well as the way that those hormones attach to the receptors, and so chemotherapy can affect menopause. And then pelvic irradiation, so any sex or any cancers that affect the sex organs that receive radiation can cause onset of menopause. Menopause is defined as permanent cessation of menses, so no bleeding for a consecutive 12-month period. So amenorrhea for 12 consecutive months. Remember, these are consecutive months, so if she has 9 months of amenorrhea and then has a cycle, the clock starts over again. So menopause is always a definition by retrospect, and you have to look back at the last 12 months that she's been amenorrheic, and so now you can define menopause. So menopause is a full 12 months of amenorrhea, and it will have hormone levels that do fluctuate and change over time. You don't need to memorize all of these, but these are pulling back from P1, talking about how sex hormones are derived from cholesterol, and we see through the process that we go through a number of different hormones. We see DHEA up here, and then turning into testosterone and androstenedione, and all of those will eventually lead to our estrogen products that are throughout our body. Depending on which estrogen is being produced, it can have variable effects. And so all cholesterol is then made, not all cholesterol can be made into some of these hormones that you recognize. So the progesterone, that gets converted into androstenedione, testosterone, and then that gets processed through our aromatase enzymes into estrogen. So females do make testosterone, and then it gets converted to estrogen, and so you can see this process. This is occurring within the ovaries mostly, although we do have aromatase enzymes outside of the ovaries and in several of our tissues throughout our body. And so all of our sex hormones are mostly made in our ovaries and then converted in the ovaries or elsewhere in the body. This is what it looks like as a deep dive into there. So we see cholesterol going into the different levels of the ovary and then being released as estradiol, and through the process converted from estrone to estradiol. And so we'll see that with menopause, we stop this conversion here and we kind of get stuck with the androstenedione and the estrone. So to review just briefly, estrogen is stimulatory. It increases breast tissue and endometrial tissue, and then progesterone is kind of the counterbalance to our estrogen, and this helps to keep the endometrial lining in check so we don't have hyperplasia. And then testosterone, we know, is a masculinizing hormone. It does increase libido to have higher levels of testosterone, so obviously decreased testosterone levels would cause decreased libido. And so we see how these hormones kind of function naturally within our body. And biologically, we have 3 different types of estrogen that we can manufacture as females, and men too. But in females, we have estrogen that is most common in our reproductive age would be this estradiol, E2. That is a very potent form of estrogen, as we see at the bottom here. And then in pregnancy, as she becomes pregnant, she would convert to an estriol rich environment that's really low estrogen efficacy and more progesterone dominating while she's pregnant. And then through menopause, she can no longer convert to these estriol and estradiol products, so she lives in estrone rich environment, and that is your menopausal, very low potency estrogen that we'll see in menopausal transition. There are different estrogen receptors throughout the body. You'll notice that most of these are in the female organs, although they do work all over the body, and we have ways of that these estrogen receptors work to help with our cardiovascular system as well as our bone development, our brain. So it's not just sex related or sex hormone related. Naturally, this is endogenous estrogen effects is listed here. these are how our estrogen will work when it's within our body, and you'll see that that's in opposition to how progesterone works within our body, where estrogen has very opposite effects to our progesterone naturally. And to review, when we give estrogen and progesterone exogenously, like when we take it orally or transdermally or however it gets administered, it will not necessarily work the same way that it would work if it's naturally made within our body. So we have the effects of estrogen and we have the counter effects of progesterone listed here. One thing to note is this is also going to be a preview towards talking about osteoporosis, since one of the leading causes of menopause or of osteoporosis is this lack of osteoclast control and the lack of osteoblast activity that we see through menopausal transition, which we'll get into at the end of the lecture for Menopause and Osteoporosis Day. All right, so staging of reproductive age is the STRA plus 10 criteria. This was recently published and helps to identify the transitions through menopause and how we can diagnose the transitional periods. And so there are two criterion that are used in staging menopause. That is the bleeding criterion and the FSH criterion. Each of these together are criteria for staging menopause. So looking at how our axis works, we have our hypothalamus releasing this GnRH. That GnRH is received by the anterior pituitary and increases our FSH and LH, that then goes to our ovary to stimulate our estrogen production. And so as we're able to make enough estrogen, our inhibin B comes back and inhibits the production of FSH and turns that off so it stops making additional. But in menopause, what you'll notice is this feedback is no longer there. As we no longer make estrogen, we have lower estrogen levels, and so then we end up trying to stimulate that with more FSH. And that's what it looks like when we see it here. Our estrogen is on the decline, and then our FSH is on the incline and then plateaus over time. And this is where we see the menopausal transition, is this period around here. From left to right is the menopausal transition. So early menopause, our primary diagnostic criteria is bleeding criteria. So number one, if we can use the bleeding criterion, we're going to use that as our primary diagnostic. And then if we cannot use that, we back it up with an FSH criterion down here at the bottom. So early transitional menopause is defined as a change in bleeding. So instead of menses being their routine cyclic frequency, they get extended 7 days beyond what they're normally transitioning. So let's say that an average female has menopause every 28 days. And so as she starts to have menses maybe every 35 days, 37 days, 40 days, that would be 7 days beyond her normal cycle. And so the longer time between cycles is definitive of or diagnostic of this early transition period. So 7 days delay in menses that is consistent. It can be additional, it could be longer than 7 days, but at least 7 days of extended duration between cycles is defined as early menopausal transition. At this time, the FSH levels are variable, so you cannot use the FSH to stage early menopausal transition. Late menopausal transition, we have our primary criterion being bleeding criteria. This would be when instead of just the 7 days, now we've gone to 60 days. So 60 days of amenorrhea means that she's extended those durations between her menses or her periods by at least 60 days. And that could also be exemplified by 2 missed periods in a row. This would be consecutive 60 days between periods would be defined as late menopausal transition. And here we can back up with our second criteria being our FSH criteria. Here, if we draw the FSH level, anything above 25 units per liter would be defined as late menopausal transition. So just to remind you, bleeding criteria is our primary criteria. It can stage early menopausal transition when menses delays 7 days or longer, and then when the delays are at least 60 days apart between periods, then we would call that late menopausal transition, and we can back that up with an FSH criterion using an FSH level of greater than 25 being definitive or being diagnostic of late menopausal transition. There are a couple terms that you should be familiar with, and you may have heard these already before. So perimenopause is the time that it takes from the start of the menopausal transition all the way to when she becomes postmenopausal. So peri means you're going through it. That is the transition from early, late, and then postmenopausal for the first year. All the way up until she has been amenorrheic for 1 year, from the time that she starts to have irregularity in her time between periods all the way up to where she's been amenorrheic for 1 year is considered perimenopausal. And that will overlap with 1 year of postmenopause, since postmenopause is defined as the time period following the final menstrual period. So these will overlap a little bit, and we'll look at that, what it looks like on a graphic coming up. There are different phases of postmenopause, but we won't go through that detail. Just realizing that everything following the 12 months of amenorrhea, all the way from your final menstrual period and beyond, is considered postmenopause. So postmenopause is any time following that final menstrual period. Of course, you won't know that it's her final menstrual period until she's had 365 days or 12 months of amenorrhea, and so it's also a diagnosis of retrospect. So menopause is defined as that 12 months of amenorrhea. It's always looking back. 1 year after her final menstrual period, you will diagnose her as menopause. She's no longer perimenopausal, and now she is postmenopausal. There are some situations where you cannot use the bleeding criteria, and that makes sense if you think about it. If she doesn't have a uterus, she's had a hysterectomy, she's no longer able to bleed, then you could still use that FSH criterion alone. And we know that an FSH greater than 25 is going to be diagnostic of late transition menopause. And then endometrial ablation is where they've gone and laser removed the endometrial lining. So they've burned the endometrial lining to promote cessation of menses. So she's no longer able to bleed, and you would have to use the FSH criterion alone. In these two cases, there is no bleeding, and so you can't use that criteria, and you would have to back up with just the FSH alone. And we know that an FSH greater than 25 is diagnostic of that late transitional menopause. In some situations, you cannot use the straw plus 10 at all. And an example of this would be with PCOS. You're going to learn about what polycystic ovarian syndrome is, but here we see variability in bleeding and we see variability in sex hormones. So her FSH criterion is going to be unreliable, as well as her bleeding is going to be unreliable. She may have irregular bleeding patterns, and she may have irregular hormone production based on her PCOS syndrome. And so then you cannot use the straw plus 10 in PCOS. Additionally, if someone has extremely low body fat or anemias, these can also cause her to not have proper bleeding, and so then you may not be able to use these criteria. Specifically with the body fat, we have excessive exercise, so extreme bodybuilders that have really low fat content, and then cachectic HIV/AIDS patients that have really low body fat also would not be able to use the criterion. And then some medications, alkylating agents, tamoxifen, these are going to affect how estrogen works in our body anyway, and may change and cause menopausal symptoms because of how they're working. So these are going to be criteria where you cannot use, or these are going to be situations where you cannot use the straw plus 10 at all. Now this graphic can be confusing for some. I really like it because I think it helps to visualize what's going on here. We'll see here on the left side that we have reproductive age. If we draw a line down here, this is your reproductive age on the left. In the middle, we have menopausal transition, we have early, and we have late. And then we have postmenopause here on the right. And we see that menopause is occurring right here 1 year. Oops, this is your final menstrual period, and then 1 year directly after that would be menopause up here at the top. All right, so we see these three transitions just kind of shown here for you. We have reproductive age, there's changes in the principal criteria for menstrual cycling, it should be regular, and then we should have, down here we have our FSH criteria also labeled. So if we look at the top again, we have menopausal transition early. Early, if we look down the column right here, we have early menopausal transition will have 7 days difference in her cycle length. So she's extending her periods by longer than 7 days between each cycle. And if we look down to the hormones, there's going to be no reliable study for her hormone levels. If we look at the next one being late stage menopause, that's this column here. If we look down, there's variability in how long this can transition, and we'll see amenorrhea for at least 60 days, and that would be a droppage of about 2 cycles or more, and that will be amenorrhea for anywhere from 60 days all the way up to 364 days, right? So she could continue to have extended durations between her cycles, like let's say that she goes 180 days and she has another period, that's going to restart that final menstrual period countdown, right? So she could be amenorrheic for 60 days or longer, and that would still be called late menopausal transition. And if we look down here, we see FSH becomes diagnostic of late menopausal transition when an FSH level is above 25. In the center here is what I was talking about. So in the center here, if I could change my pen color, in the center here is perimenopause. So perimenopause is going to be all that time between when she has early transition, where her periods start to extend 7 days longer between cycles, all the way up to late menopausal transition, where she's starting to drop cycles and she's going 60 days or longer between periods. Her FSH will also be elevated above 25 at this point. And then she'll have her final menstrual period here, and then all the way out to 1 year following that final menstrual period is when we finally diagnosed menopause. She is no longer perimenopausal, and she's now postmenopausal for that duration forward. So we do see that overlap in this section here, where there's 1 year where she'll be both perimenopausal and postmenopausal while we're waiting to diagnose menopause. Okay, so remember, menopause is 1 year following final menstrual period. We can review this a little bit in class, but just kind of think about it, look at this, draw it out, figure it out, because it is just being able to define each of these transitional periods. So at birth, a woman is born, a female is born with about 2 million primordial follicles. These, however, do not all turn into mature follicles. In fact, most of them die within her lifespan, so she will ovulate about 500 times. So from those 2 million, we get about 500 mature follicles, and the rest will go through cell death. And the changes that we see associated with menopause are mostly related to that ovarian follicular activity decline. So she's no longer converting her testosterone to that active estrogen. She's kind of stopping at the testosterone level, and even that production is significantly lower than her normal levels. And so remember that the ovary is the primary site for that conversion to the active estrogen, in which case in perimenopause and postmenopause, she's no longer able to produce that really nice reproductive age potent estradiol. Progesterone levels become immeasurable following menopause. So while she's going through reproductive age and the menopausal transition, she has had higher levels of progesterone, and then through the menopausal transition, she declines that progesterone effect and eventually gets to immeasurable levels of progesterone following menopausal transition. That puts her in an estrogenic predominating environment, but the estrogen that she is producing is very low potency relative to her reproductive age. So progesterone, immeasurable. Estrogen is going to be that estradiol or estrone-rich environment, so she's declined her estrogen production, and then testosterone is going to be also significantly decreased concentrations. So that's where we can lead to some of the symptoms related to low libido in our older adult women population. And so even though your ovaries are still capable of producing the testosterone, it's in much significant effect or much significant decline compared to her reproductive age comparison. Estrogen, as I mentioned, is going to decrease production of estradiol, and it's going to remain an estrone-rich environment, which is a very low potency estrogen compared to her reproductive age estrogen, and that's going to lead to all of the menopausal symptoms that she may experience. Decline in the estradiol levels will cause a lot of these symptoms, including vasomotor symptoms, which we'll talk about most extensively, being the most common and most common and intolerable effects of menopausal transition. Sweating, irritability, sleep disturbances, atrophy of the vaginal tissues, as well as the genitourinary symptoms. Osteoporosis and bone fractures can be caused by this lack of estrogen. This is a big one that we're going to talk about on its own. Coronary artery disease is increased in this population to the point that as women age and go through menopause, they actually become the leading sex related to coronary artery disease. So where males are predominantly high risk coronary artery disease in their younger years, as women get to menopause, they actually increase their risk for coronary artery disease and become the predominating gender related to coronary artery disease in advanced age. Can also lead to memory loss and cognitive difficulties. So all of these, you would imagine, are less desirable, and so that's some of the complications associated with menopause. Symptoms that we're going to talk about how to treat are going to be these vasomotor symptoms, and we'll learn about how to administer hormones to help offset some of the significant symptoms that they may experience, most classic being hot flashes and night sweats. Sleep disturbances, we don't really have great drugs to treat that. We kind of try to do non-pharmacologic intervention. Mood changes, irritability, and anxiety. Problems with concentration and memory also don't have a great drug option. And then vaginal dryness and dyspareunia. Make sure that you look up any definitions that you don't know. Dyspareunia is pain during intercourse, and so this could be related to the vaginal dryness or the vaginal atrophy as tissues in the vulvovaginal areas are changing with menopausal transition. And then sexual dysfunction can be related to this dyspareunia, or it can also be caused by that decreased libido related to the menopausal transition. Some signs of perimenopause are going to be, obviously, your primary sign is going to be your bleeding criteria, and then menopause would be when we have cessation of menses, and then they also may experience urogenital atrophy, which we'll talk about. You want to make sure that there's not another cause for this uterine change in the bleeding patterns, and make sure that that is a differential diagnosis. And so we want to evaluate objectively using the bleeding criteria as your primary diagnostic criteria. You may also do FSH as a backup. That will be defined as FSH greater than 25 would be diagnostic of late menopausal transition. That's kind of your backup criterion. And then other tests that you want to run is thyroid function tests and iron stores. So as I mentioned, iron stores, if people have anemias, they're not going to be able to have regular bleeding, and that can cause changes in their bleeding patterns. And then FSH and other thyroid dysfunction, so thyroid function issues, can impact your FSH as well as your bleeding. And so your sex hormones as well as your bleeding can change with issues with your thyroid. So these should be differential diagnoses that are conducted to rule out any other problems that could be causing the issues that you're seeing. So that brings us to the end of the section that we're going to cover in this video, and then I'll see you in class to keep going with the remainder. Please watch any portions of the video that seemed confusing to you, go back to that table a little bit and work through it, make sure that you're ready for class, and come prepared with any questions that you have so that we can roll straight into treatment and talk through anything that is unclear. I look forward to seeing you in class. Thank you. Have a great day.